of lecture, that is Learn Radiology Basics from Professor. Today's topic is tuberculosis of joint evaluated by plain X-rays. So radiography gets good information about the tuberculosis. It is a very useful tool in diagnosis of tuberculosis and it is the best investigation. It is often said that what is the role of plain X-ray? In today's lecture, we are first going to see a radiological aspect. We are going to see the pathological features and how they are reflected on a plain radiograph. So serially we will be seeing first the radiological aspect, then the pathological features, and then how they reflect on the X-rays, and lastly a film reading session. Since the topic is large, we are divided into two parts. Now today's first topic is the part 1. Now this is the disclosure or disclaimer. Material which we are using for interpretation and film reading session is my personal, and the illustrative purpose, certain theoretical aspect, certain pathological aspect, they are downloaded from net, which are available as free of cost and royalty free. So here we go to tuberculosis of joint evaluated by plain radiography. Now plain radiographic approach. Radiographic approach part 1, we are going to see introduction, types of arthritis, radiographic techniques, different imaging modalities which can also evaluate joints and give us good information, diagnostic information about tuberculosis, and basic approach towards arthritis, that is its classification and how to make use of the imaging techniques. Now joint pain is a very common symptom in medical OPD or which your hospital, medical, surgical, whatever it is. In OPD, a lot of patients come with a joint pain. Now, it is not always possible to arrive at a diagnosis just by medical examination or by clinical examination. Under that circumstances, we will have to go for certain of the radiological modalities to evaluate it. Now, let us see first what are the types of arthritis. Types of arthritis include primary osteoarthritis. It is a degenerative osteoarthritis that is seen in elderly. Then there is secondary broad category of inflammatory arthritis. Now all these inflammatory arthritis, which includes rheumatoid arthritis, psoriatic arthritis, ankylosing spondylitis, erosive arthritis, are going to be covered in this lecture. Now there are also certain metabolic diseases which can cause a picture like arthritis. Now they are gout, pseudo-gout, etc. Now there are certain connective tissue disorders like systemic lupus erythematosus that can also manifest as a joint diseases. Now infectious arthritis like tuberculosis or septic arthritis, which is our today's lecture topic. Now radiology plays a major role, particularly plain X-ray, because it is a frontline investigation. Now how you prepare a patient and what are the preparation required in the department when you take patient or when you go for radiographic examination. Most important, we have to see that radiation is contraindicated in certain conditions. Now we have to confirm before taking any patient to radiology room, this patient is not pregnant or patient is not suspected to have pregnant. Now sometimes it is evaluated with X-ray, and sometimes we have got boards in the X-ray department where it is clearly mentioned that if patients are pregnant, they should give idea to the radiographer and to the referring consultants before coming to radiology room. Now, otherwise there are no really preparations which are required for joint radiographs. A painful joint history is need to be taken before, because we are going to sometimes make the leg straight, arm straight. It may be a painful, it may not be possible for the patient. These things has to be taken care before taking patient to the radiographic room. Now part of radiography which we are going to take X-rays should not be covered by radio-opaque objects. What it means, suppose you are taking a X-ray of wrist joint, it should not be covered with bangles or anything which should obscure the wrist joint details. So the part that is going to be radiographed should not be covered by any radio-opaque objects. Now information about metal implants and other can be given, but really it is not a contraindication, since there are not much artifacts which are produced by the implant used by orthopedic surgeon for treating fractures, and one of the indication of this is to know where is the situation or position of the implant. So that is not a real contraindication for plain radiography. Now, is there any risk for the X-ray? Theoretically, yes. X-ray is a procedure that carries a minimal risk of cancer, but I think it is too negligible, too minimal, and should not be considered against its benefit it is going to give us. Now, level of radiation we are going to use, the type of X-ray we are going to use, they are really harmless. Not 100%, but for all practical purpose, we can say that they are harmless. Then in case of X-ray, if we take it, it may or may not be informative. What we feel is a baseline investigation, but if it is not adequate, then we have to consider other possibilities like sonography, CT, MRI, and these will be implemented as per the indications. While going in the details of this lecture, we are going to see all these things and where to apply CT, where to apply MRI, and where to apply sonography. All things we are going to discuss in detail once we go ahead in the lecture. Now, what is the procedure for obtaining X-ray? The relatives should not come in the room because really there is no need to expose these people for radiation for no risk. So usually the patient alone comes in the radiography room. Relatives are not allowed. The mobility of joint to be radiographed should be assessed before. That is to avoid pains, and if there are pains, patient may move. So we have to assess the mobility of joint before going for the X-ray. Radiographs taken maybe all the time or sometime on a radiography table. So that is when patient is sitting to the side of the table and the hand or wrist or shoulder is kept on the table, and that is radiographed. Rarely we have to take standing X-rays, and one of the more important indication is to check the instability of the knee joint, and second is early osteoarthritis to know the cartilage losses. But otherwise, whatever joints we are going to see in this study, they are usually one side affected joints, and most of them needs no standing radiographs. They need oblique sometimes, either right side oblique or left side oblique. Now, whenever possible, left approach should be used to the rest of the body. What it means that if patient's shoulder we are taking, then it is not possible. If we are going to take the elbow, we have to cover the remaining body with the left apron, and same case is with the wrist and with the knee joint. Yes. Then it's a small procedure. It doesn't take more than 1 or 2 minutes. But sometimes the patient has got pain, then we have to tell the patient to cooperate with us. Sometimes it takes for the counseling the patient, and sometimes it needs more time for patient to settle down. So time is not really a factor, and it should be used whenever possible, more time also. Now, what are the basic X-rays we take? Either anterior posterior or posterior anterior, lateral, or one or the other obliques as per the indication. Baseline X-ray is AP. So you go for AP projection and then plan either oblique or angulation of oblique or a lateral one. Then earlier we used to have 2 different projections for soft tissues and bones. That was the wet processing. But nowadays on CR system, we do not have to go for different projections. A same radiograph can work for both soft tissues as well as bony details. That is the joint space also and the surrounding tissues also. Now, other modalities for joint pathology detection, that is MRI. We are going to see X-ray, we are seeing it, and we are going to see also in more detail. This is just a passing remark when to apply MRI. But of course we say that first is the plain radiograph. According to the indication, we go for MRI. Now, which are these indications? Now, MRI shows a reactive bone edema better. So, bone marrow edema is better appreciated on MRI. Then inflammation of the tissues as well as degenerative changes in the cartilage or bony small fragments are better appreciated in the MRI. Now, MRI has got certain specialized protocols which can give, or sequences which can give you more detail about the early cartilage degenerative changes. So if there are early degenerative changes in cartilage, certain MRI sequences gives you a good idea. Now that is HSS. Now this is also helpful for early diagnosis and for prevention of delay in the disease process. What does it mean? It takes time for a radiological manifestation of certain diseases. However, when X-ray is normal, still MRI can show us the changes. So one of the indication for MRI is you are suspecting joint orthopathy, but when the plain X-rays are negative or not. Which are the other modalities for joint pathology detection? Does ultrasound has got any role in it? Ultrasound has got a limited role and it is always secondary. Now it is a sensitive for identification of synovial cyst that is not seen on plain X-ray. Number 2, joint effusions. If effusion is there, we get a good window and we can assess the articular surfaces also. And it is excellent in evaluating ligament, tendons and surrounding structures. Like if the tendon is torn, if there is bursa which is inflamed. Now inflammation of bursa can be detected by color Doppler. So this is few of the indication for ultrasound, and our routine practice is we combine after plain X-ray according to the indication ultrasound. So ultrasound becomes a almost after the X-ray next investigation of choice, depending on what is the type of pathology we are seeing and whether we are sure of getting some additional advantages. Now confirmation of diagnosis. You are going to take the patient for X-ray, you are going to take the radiographs, you are going to suspect a tuberculosis. Now, right now we are going in some theoretical aspects. So in that, one of the examination or one of the tests one would like to know is how to prove whatever we are saying is a tuberculosis arthritis or not. So synovial fluid examination is very easy. Ultrasound helps a lot in guiding, in telling whether we will get it from which space, and it is easy to get it or not easy to get. So synovial fluid examination, but synovial fluid examination has got its own limitation. Though we can have certain tests like a culture, then centrifuge samples, then there are certain ingredients of synovial fluid which can lead to suspect a tubercular disease. But that all is not as sensitive or not as accurate. Now if you want to have a 100% diagnosis, the gold standard for diagnosis of tubercular arthritis is synovial biopsy. Now synovial biopsy, either we can go with ultrasound, we can go with the CT, but there are certain difficult joints like SI joints where we have to go for CT to obtain the biopsy. So biopsy is not always possible on X-ray or on fluoroscopy. So we have to take additional assistance. So this is we are talking as far as a diagnosis establishment is concerned. Now the synovial biopsy can also tell you about the caseation, about the lymphocytes, about the granulomas, and sometimes you can get tubercular bacilli also. Now let us come to a radiological diagnosis. We have taken a X-ray. In that, one of the most important historical aspect, that is the patient's history taking, is which joint is affected, what is the duration of affection, how many joints are involved, it is a single joint or there are multiple joints, is it symmetrical, is it asymmetrical presentation as far as patient is concerned. In his history we have to take all these details. Now after the X-ray is taken, after we take it for the interpretation, what we see first is a joint space. Joint space widen, preserve, narrow. Now as long as joint space is normal, then we will have to think of some other pathologies also. Then again we go back to the history, if the history is short term or long term. Now destruction of hyaline cartilage by tubercular bacteria is a slow process. So patient has got pain, it goes towards chronicity, and in that we find the X-ray is normal, we start thinking of tuberculosis. If the history is short, if there are more destructive changes, no, we are going away from the diagnosis of tuberculosis in by and large patients. It's not a thumb rule, but it's a by and large. Now bone destruction is seen in epiphysis or metaphysis. Now we are going to go for our film reading session in next series. In that it is demonstrated. So the destruction is seen in epiphysis or in metaphysis as an ill-defined radiopacities without normal calculations. So it is important to find on plain X-ray what is a destruction, and what is a normal bone. Now we are continuing with the salient features of bone pathologies or joint pathologies or cartilage pathologies in tuberculous arthritis. Now reactive bone formation is absent in early case of disease. When a reactive bone will form? When there is destruction of the routine bone. When there is no destruction of routine bone, it will come as the late. So when bone will be destructed, there will be reactive bone formation. When bone will not be destructed, there will not be a reactive bone formation. So in early stage, there is no reactive bone formation. Reactive bone formation is a healing indicator. Now, what does it mean to the radiologist? One thing, it is late. So when it is seen, you are very sure that the disease process is going on wrong process. It has already eroded the cartilage and it has already disturbed the articular surfaces, and then it has entered the bone. Now in this, reactive bone, whether it helps you for detection, yes. Whether it helps you in prognostic, also yes. Because once we start anti-tubercular line of treatment, the reactive bone start forming. And more reactive bone formation gives you more and more idea that the treatment is going on the right channel, patient is getting better, and patient disease is healing. Now sequence stars are there in tubercular arthritis. They are not as common as pyogenic arthritis, they are less common, and in tuberculosis, sequence stars are not common, they are there. And after destruction of cartilage, exposed bone will be attacked. So what will happen first? First the organisms will go to the cartilage, then discharge of cartilage. Now that changes how we are going to see is a loss of cartilage, number one. And second thing is MRI is going to show you different changes in cartilage in very early stage. Now when that stage is crossed, the tubercular bacilli will start attacking the bone. Now this will result in destruction of the cartilage, destruction of the bone, and then it will go to the deeper bones, and that will form a deformity. Which are the other supporting investigation for tuberculosis? CTC is not specific. Anemia, leukocytosis may be associated features. Raised ESR, yes, it should be considered as a sign of tuberculosis. Tuberculin test has got a limited role as far as the age of patient is concerned. In elderly, it is not considered a reliable. So also, it is usually, if BCG vaccine is given, has got a limited role. So that is another thing which we have to check before asking for a tuberculin test. The synovial fluid, as I told you, whether it gives you WBC count, whether it has given you low sugars, or it has given you low mucin, it has got its limited role because it fails to show you a specific tubercular organisms. You may go for a centrifuge sample. You may go for the diagnostic and we go and check the tuberculosis bacilli, but by and large it is not as good as sensitive and 100% confirmation. So confirmation, if all tests fail, has to be by synovial biopsy. Let's come to clinical presentation. Most of patients are middle-aged or elderly. So tuberculosis usually affect a middle-aged or elderly. However, it is not rare in children, especially in hip joint. Hip joint, it is more common in children. The tubercular bacilli lodge in synovial or epiphyseal portion of the bone, and from there they spread to the joint. The end stage of tubercular arthritis is fibrous ankylosis. Now please note, fibrous ankylosis, bony ankylosis is not a feature of tubercular arthritis, and it is very uncommon. Though we say not, it will be there, but it will not be a common feature. Imaging approach. Any patient coming to you with tubercular arthritis, we have seen the background, we have seen primarily how patient is investigated. Now, what a radiologist need for interpretation of tubercular arthritis. Now, this is the history has to be taken by a radiologist or radiology assistant, since it is the essential features for the diagnosis of tuberculosis. Now, distribution. Monoarticular, single joint involvement, very important. Polyarticular, there are multiple joints involved. Symmetrical, both hand, both side joint, like that. So whether it's symmetrical or not symmetrical, you have to check. You have to chart down. Now this history taking is an essential part before interpreting a radiograph. Now soft tissues are also seen on X-rays. Now you have to see it on CR and go for the both settings, bone window as well as soft tissue settings. Soft tissue should give you idea about the effusion, calcification or any adjacent masses. Now, mineralization, that is a diffuse, focal, periarticular. What is the type of demineralization? Is it a focal? It is a periarticular? It is a diffuse? It is both symmetrical? It is only one side? It is only restricted to joint? It is multiple joint? That is showing osteoporotic changes. It is part of diffuse or generalized osteoporotic process needs to be considered. Now, erosions. Erosions one has to check very carefully or know very carefully. They can be, where the erosion comes is very important. Like you can get in weight bearing surface, you can get at periphery, you can get at the center. So erosion central, that is articular surface, in that again weight bearing surface, then marginal, that's the bare areas, and periarticular. So erosion where it is coming will give you a phenomenal idea about the etiology of arthritis. Now, proliferation. Proliferation is the outgrowths, that is osteophyte and periostitis. Now, if osteophytes are coming, what does it indicate? The body is trying to support. Body is putting its effort to protect. If painful joint is there, to reduce the movement. If the joint is unstable, to give the stability. So, osteophytic role has to be understood and its presence need to be interrogated. Now, deformities in tuberculosis is a part of head process. They can be varus, valgus, flexion, extension and subluxations. These can come as the late manifestations, but one has to look at it and interpret what should be done. Now, tubercular arthritis is divided into multiple stages. We are at tubercular arthritis. Now, tubercular arthritis is divided into stages. First is stage 0. Stage 0 is when there is no radiographical changes. So the stage of synovitis. This is the stage. First stage is stage of synovitis. The second stage is stage of arthritis. Second stage of advanced arthritis, and fourth is the stage of healing. So these are the 4 stages of tubercular arthritis. First stage, synovitis. X-ray change is not there. Second is practically arthritic changes you start seeing. Then are the advanced changes of that, and then starting healing process. Now we are going to see all these things when we will come to the film reading and interpretation part on the plain X-ray. Now let's have some theoretical idea before approaching X-ray. What happens in stage 1? Now stage 1 will go after stage 0. So first is stage 0. Stage 0 indicating normal radiographic appearance. Plain X-ray is normal. Joint space is not affected. Joint space is not affected. There may be chondral lesions or subchondral bone erosion lesions, but they are not seen on plain radiography. So we are not saying they are not there, but we are saying they are not seen on the X-ray. So that is the stage 0. Now where it will be positive, it will be positive on MRI. So at this very early stage, only finding will be positive MRI. Now therefore, to consider synovial biopsy is the only way to confirm the etiology in stage 0. So how it goes? You have taken the X-ray, you are suspecting tuberculosis, other blood criteria are in supportive, you go for MRI, showing some changes, you want to confirm, go for MRI. And then for, now what are these stages? Stage 0, now stage 1. This is a stage 1 is a stage of synovitis. What happens in synovitis? Soft tissue swelling. So because the synovial membrane is involved, because the cartilage is involved, it will start secreting fluid. So there will be increase in joint fluid, joint swelling, then joint widening because of the joint fluid, and there will be, due to effusion, there is joint widening, and synovial hypertrophy will be there. But this synovial hypertrophy will not be appreciated on X-ray directly, but indirectly as widening of joint space. So juxta-articular osteoporosis. What will happen in this is because of the painful extremity, because patient is having pain, patient will move extremity less. So it will lead to disuse osteoporosis. So that is the outcome of extremity came inactive. Now in tuberculosis, please note, in tuberculosis, if extremity is kept active, you will not get much of the osteoporotic changes. So osteoporotic changes essentially will tell you in tuberculosis whether extremity is kept active or it is fixed. Now, if there is secondary infection, that is superinfection, subperiosteal reaction may result. So we are not talking of this when there will be some supernatural infection. The picture will be of mixed, and we are talking right now of only tubercular arthritis. As a result of localized hyperemia, growth plate may show some growth, especially in children. It's a small request that please see my second video also, which is on the film reading. In that we have shown a couple of films where because of growth plate affection, the extremity growth is hampered. Either there can be deformity or there can be shortening of the limb. Now we'll go to stage 2. Now what happens is, stage 2, the articular margins and bony cortices become hazy, they become blurred, giving rise to a washout appearance. So this is the appearance we can appreciate very well nowadays on X-rays because of the good quality we are getting from the CR system. So this is a possibility nowadays with the CR. Now narrow joint space indicate involvement of articular cartilages. So articular cartilage is involved, it is destructive. So what it has resulted, first into effusion, first into increase, and then into a narrowing. So joint space narrowing comes as the next stage. Now what is Femister triad? It's a triad by which a diagnosis of certain arthritis is made. We are going to see it more detail when we are going to see it subsequently in a film reading session. It is going to be extensively covered in it. Now, what is juxta-articular osteoporosis? As I told you, because of hyperemia number 1, and second because of extremity can be inactive. These are the two reasons what causes osteoporosis. So, peripherally located osseous lesions. Now, these are the distant lesions which are essentially not a feature of tubercular arthritis. Now, joint space narrowing we have seen. Now, go to stage 3. Now, what happens in stage 3? Disease is advancing. Effusion is there. First 0 stage, there are no changes radiologically, but synovial changes are there. Stage 1, destruction. Now it has come to the articular surface. So what happens from the articular surface? It goes to the bones. Now there can be collapse of bone, subluxation or dislocation. Again we are going to see it in our film reading session. Then migration of bone and deformity of bone. Migration of bone is essentially features of the hip joint. We are seeing there subluxation, hip joint or in knee joint, both it can come. And deformity of bone again is more common in the lower extremity. Now stage 4. Now stage 4, what happens is remineralization. Whatever damages are there, body has got defense mechanism. Sometimes tuberculosis can be self-limiting. Sometimes it's because of the good treatment. So once the disease starts reducing, then there is remineralization. Cortical and articular margins become distant. Now, fibrous ankylosing may occur during this healing phase. So there are two types of ankylosing. One is bony and fibrous. Fibrous feature of tuberculosis. Bony is not a feature of tuberculosis. So, in contrast to pyogenic, there is fibrous ankylosing in tuberculosis. Tubercular arthritis become so in tubercular arthritis, these complications are uncommon. Which is that uncomplication is the bony ankylosis. Which is more common is fibrous ankylosis. Now, is it that tuberculosis only involves the joint? Okay. Is it that only it involves the subcortical surface? Okay. Is it the only it involves the bone? No, it can also involve many other structures, which are the tendons, sheaths, then bursa, and it can form a multiple abscesses. Let us call them as cold abscess. So, tuberculosis arthritis can be associated with tenosynovitis. It can be associated with bursitis, and it can also be associated with multiple cold abscesses. Now, how to detect? Plain X-ray will give soft tissue shadows, but the real diagnosis is by Doppler, and not only by Doppler but by the subsequent response to the treatment and needle aspirations. Now this becomes accessible to ultrasound, easy to put needle. So that is a common way that to prove it is once the fluid accumulates, the fluid can be tapped. It can give diagnosis of the joint also and of the peripheral pathologies also. Now let's come to a radiological diagnosis. As the cartilage loss becomes severe, there is bone cyst formation and sclerosis and reactive bone formation. Now this is the pathogenesis and radiological implementation we are seeing side by side. Once the cartilage is lost, bone cysts are there. Once the bone cysts are there, cartilage is lost. Once the sclerosis is there, cartilage is lost. There is reactive bone formation. The osteophyte, what are they? They are bony spurs. From where they come? From the sides. How they grow? Away from the cartilage. So cartilage destruction. So what happens is osteophyte and bone spurs are seen. These grow opposite to the direction of destroyed cartilage and joint space narrowed. What is their aim? Why they occur is to support the body. How they support? They can either try to stabilize the body or they try to reduce the movements to avoid the pain. So osteophytosis is a protective phenomenon. Now these osteophytes are formed as an attempt to stabilize the joints, then compensate the cartilage loss and narrow the joint space. So this is something like protecting a joint from a painful movements. Now what are the MRI findings in it? Now MRI signs of tubercular arthritis. We are seeing different modalities and their tubercular manifestation. Now this should be applied only when radiology feels some radiological signs are not there. Plain radiograph shows nothing. You are suspecting tubercular arthritis, then go for MRI. Now bone marrow edema, intraosseous abscess, sequester, etc. are better seen on MRI. Now what are the advantages of CT? CT can be implemented. As we have seen earlier also, when the plain X-rays are negative, this we have seen as the next step of investigation. So once the plain X-rays are negative, we go for the CT. Now what CT tells us? CT tells us lytic areas and marginal sclerosis much better and much before they seen on the X-ray. Swelling in the soft tissues, granulation, exudate abscess are seen, calcification are seen better earlier before plain X-rays. The joint space is evaluated better. Joint space is evaluated better and beneficial is in guided biopsies because SI joints are really difficult to get with anything else than CT scan. Now USG. USG we are seeing is as a offer supporting investigations in addition to the plain X-ray. The only useful for evaluation of a large joints. It doesn't work really in small joints and it demonstrates fluid effusion. And if fluid effusion is there, then only USG has got more role. As far as synovitis and capsular thickening is concerned, the Doppler signal gives you idea about the inflammation. So hyperemia, that is better picked on Doppler. So soft tissue abscesses, adjacent tissues, then cortical disruptions, irregularities, then guided aspiration of joint effusion. Everywhere we are implementing USG. What are the? Is there any additional benefits of USG? Yes, it is excellent as supporting investigation due to ability to detect fluid and inflammatory changes with high frequency probe not only in the joint but also in muscles, tendon sheath and fascia. So these are the additional places from where a Doppler can pick even minimal fluid, inflammatory changes, and it is a real advantage in these tissue planes also and also in the bursal pathology. The tear of muscle tendon can be picked by Doppler easily and it can detect synovial cyst in osteoarthritis and detection of bursa in inflammation is an added advantage. Now here we have seen all theoretical aspects. We have not even seen a single plain X-ray. We have not seen even a single radiographic sign. Till now we always seen what is the role of plain X-ray, what are the things to be seen in plain X-ray, what is a pathogenesis, how a pathogenesis is reflected in the X-rays, how that is to be interpreted, what is the limitation of X-ray, when to say that enough from the plain, let's go to other investigation. As far as my personal opinion is concerned, the second investigation of choice depends on the patient's clinical settings, either as an ultrasound or as a MRI or as a CT. We have seen what are the advantages of MRI, what are the advantages of CT when there are no plain radiographic diagnosis. Now this we have seen in this. This was a part 1. Now what we are going to see in part 2? Part 2 we are going to see again the pitfalls, then what are diagnostic features, what makes you think that it is tubercular, what makes you think that don't think of tuberculosis, What are the guidelines to know whether the changes are progressive, whether the healing is taking place, or the disease is healed? So all these things we'll be seeing in part 2. With this, we are coming to the end portion of our today's lecture. Today's lecture, I have already explained you about everything theoretical, and we are going to see a practical in next part 2. I, Dr. Anil Joshi, thank you for giving me your valuable time. Time is really valuable, and I really feel myself lucky that you have given me your valuable time. In this valuable time, in my honest effort, I tried to tell you what I know about the tubercular arthritis, and I am going to tell you more in part 2 how to approach a radiographic diagnosis. Please note, radiology is not a race, it's a process. Be a part of this process and enjoy the travel through it. So be a part of this process. It is not a number race. Get involved in more and more diagnosis. Try to analyze them. Correlate them with the pathologies, and that will give you a really excellent idea how you can benefit patients with a very small investigation which is available everywhere, which is available in most of the center, which can easily be taken and which is not really costly, but it gives you a fabulous information. I am Dr. Anil Joshi. Logs off till we meet